In this video, we'll talk about nuclear medicine gastrointestinal system imaging, particularly focusing on the GI pathology studies. Recall that gastrointestinal imaging can be divided into three categories. You have the GI transit and motility studies, hepatobiliary studies, and all the variations of a HIDA, and then the GI pathology. And that's the one that we're going to be focusing on in this video. So let's talk about the liver hemangioma study. On this first image that you see here, this is a SPECT-CT study, which is fairly common with hemangioma to do a SPECT or SPECT-CT. And that's because really we're looking to see if it's cavernous. And the only way to see if there's necrotic tissue within it and if it's cavernous is to look at it in the 3D plane and look at it from different views. And so the image you see here in the top left is the CT. CT is not great for hemangioma. You can do a 3-phase liver, and that will show you different areas of blood pool within the liver, and that should help to differentiate. But again, it's not that great. It's really hard to see because it's not the liver on CT very much homogeneous, not a lot of internal contrast resolution. So you see here on the CT, you can't really see if it is a hemangioma or not, but where that red is kind of localizing it. And then the image here in the top right and the one below it are the SPECT views. And this is the same angle. So this thing that's a little bit more intense here is the spleen. Remember, this is tagged red blood cells for this study. So what you see kind of triangulated with the red crosshairs there is the hemangioma. And you can see that it is concentrating the blood pool in that area, and the rest of the liver, not so much. Even though the liver is highly vascularized, not as much as the spleen or hemangioma. So it shows up a lot fainter. And then this is a transaxial view. And then in the bottom left corner, you see the SPECT-CT fused images of the same views. And you can see where the things that aren't quite as vascularized or intense are blue, and the areas of the most intense activity are orangish color. So you see the spleen here on the right of the image, which is actually the patient's left side. You see the aorta there, and then you see the hemangioma within the liver. So it's very useful to use SPECT and SPECT-CT for liver hemangioma. I do want to point out that this study is sometimes just called hemangioma, but a hemangioma is a benign mass of blood vessels, and you can have them anywhere in your body. So sometimes it's more accurately referred to as a liver hemangioma study or liver blood pool imaging, and it all means the same thing. So the rationale is that the hemangioma is really a benign mass. When we're imaging it, it's a liver hemangioma. So it's occurring in the liver, and it's made up of just a tangle of blood vessels. Cavernous hemangiomas are the most common benign tumors of the liver. This study is very important, though, because they are a little bit isodense, not a lot of contrast resolution, and not a lot of differentiation between what kind of tumor it is on a CT or an MRI. So the hemangioma study that we do in nuclear medicine is really great at differentiating between the benign hemangiomas from something more serious like a malignant liver carcinoma in patients with equivocal findings on CT, MRI, or ultrasound. And our study is especially important because without the nuclear medicine study, the only way to really tell what that is, if it's malignant or if it's a hemangioma, is to biopsy it, which can be a very invasive and risky procedure. And it carries a lot of other complication risks with it because it is a blood vessel or a mass of blood vessels. You can get bleeding, clotting, things like that. Hemangioma lesions are less than, or Hemangioma lesions that are less than 2 to 3 centimeters and as small as 0.5 centimeters can be detected with SPECT. So that's one reason why SPECT is preferred when you're doing this type of study. So the indications are just differentiate between hepatic hemangiomas and other liver lesions like malignancies. Contraindications, pregnancy or breastfeeding. Remember, breastfeeding is not an absolute contraindication. They could pump and waste the breast milk for a period of time. Any recent interfering nuclear medicine studies, this would be anything where they've had tagged red blood cells or any activity, tech-based activity in the liver already, like a liver-spleen study, anything like that, anything that was given that was excreted in the bowel or the liver might show up would be interfering study. And then recent barium studies, because of course that will attenuate and can cause false negatives. So the radiopharmaceutical of choice is the 99M technetium tagged red blood cells. Dose is typically anywhere from 20 to 25 millicuries, although I have seen them go up to 30. And in vitro labeling is preferred due to the increased labeling efficiency. Again, this would be the Ultra Tag kit. You'll have a much higher tagging efficiency. Free tech would show up in the gastric mucosa and in any areas of ectopic gastric tissue. That could interfere with the test a little bit. It's just not ideal. Patient prep, they can eat and take their medications as usual. This is another one where they don't necessarily have to be NPO. Medical history should include relevant history and results of a physical exam, results of any other diagnostic test, especially CT or ultrasound, and any symptoms that the patient may be having. So the procedure starts with explaining the patient, the procedure to the patient and taking a patient history. And then you want to label their red blood cells. That takes about 20 to 30 minutes with the UltraTag kit. You heparinize the syringe, just barely enough heparin to even coat the inside of the syringe. Withdraw about 3 cc's of blood, and then you tag that according to the directions in the UltraTag kit. And then when you're ready to give it back to the patient, remember, you never want to shake the tagged red blood cells. You don't want to have any kind of foam present when you're withdrawing it or injecting it into the vial or withdrawing it back into the syringe. That means the red blood cells have been damaged and that can interfere with the tagging. It can also lead to more uptake in the spleen, and you want to inject those slowly back into the patient so you can avoid damaging the red blood cells. And then the patient will be positioned supine under the camera in the position that will best demonstrate the lesion. So this is where it's important to look at any other studies that they've had in the past, because that will tell you if the hemangioma is more on the side and the anterior or posterior of the liver. Wherever you're most likely to see it, that's where you'll start your dynamic, your flow imaging, followed by immediate blood pool. The delayed blood pool imaging is 45 to 180 minutes after injection, and the same views that you took in the earlier images. So you'll do the flow, anterior, posterior, and right lateral. And then if the lesion is really small or there are multiple suspected lesions, SPECT is recommended. SPECT is also recommended if you're trying to see if it's a cavernous hemangioma, because you'll be able to see all the different angles and slices that way. And the patient ideally should be positioned supine with their arms above their head. These are the acquisition parameters. Energy is 140 keV with 20% window. Collimator is low energy all-purpose. Patient position is supine. Camera position is dependent on the lesion location. Injection to imaging time, immediate. followed by immediate flow and blood pool imaging, followed by delayed blood pool imaging 45 to 180 minutes later. And so it's anywhere from about 1 to 3 hours later. And then the SPECT is done at the delayed imaging. The acquisition type is your initial flow, followed by some planar blood pools and delays, and then planar images go for about 1 to 2 million counts. The matrix is 128 by 128 for the flow. You can use a little bit more detailed images on the planar. So those would be 256 by 256, and SPECT is 128 by 128. The initial flow is 1 second per frame, and then planar is 1 to 2 million counts, and SPECT is 20 to 30 seconds. The SPECT orbit is 360 degrees. You want to go all the way around the patient in circular or non-circular orbit. Circular orbit or contoured is going to be best because you're looking at the abdomen and it's more likely to be elliptical shaped than circular. So the processing, you want to sum the dynamic images. You did do that flow of about 1 second per frame. So you could sum those to 2, 3, or even 5 seconds per frame, scale them, and then label them appropriately. If you did a SPECT with it, you'll reconstruct that data and display it in coronal, sagittal, and transaxial projections. And then the image findings, if there is a hemangioma, you'll typically have decreased or normal perfusion on the flow, and then markedly increased uptake in the delayed images. This is because that hemangioma is taking up space in the liver. And when you see that initial flow, you're seeing the blood pooling within the liver tissue itself. And so that will actually be decreased perfusion initially when it's in the liver tissue because the hemangioma is just taking up space. But then as it starts to pool in the blood vessels, you'll start to see that there's a lot more increased uptake in the actual hemangioma compared to the rest of the liver. And this image here on the right is a hemangioma. You'll see the outline very faintly of the spleen of the liver. You'll see the spleen here with a little bit increased uptake in parts of the spleen. You'll see the vascularities down the abdomen that bifurcate to go to each leg. You'll see activity in the bladder. You see the heart. And then where the arrow is pointing to, that is the actual hemangioma. And this one looks like a cavernous one because you see some areas of decreased uptake in the center, but really a SPECT study is going to be best to illustrate that. And this is another example of a hemangioma that's in a different part of the liver. This one is in the lower lobe, but you also have one in the upper lobe. So you see the heart here in the center. This gigantic thing is the liver. There's a little caret pointing to the smaller hemangioma and then an arrow pointing to the bigger one. And then you see the spleen over there on the right side of the image, but it's the patient's left. And this is an example of a SPECT for hemangioma. You'll see over here on the summed images, you see the heart, you see the spleen, both kidneys. You'll see the outline of the liver real faintly with the hemangioma in the center. And then you see the major vessels of the abdomen, and then they bifurcate there to go down each leg. And so the top here is the transverse images. You see the hemangioma showing up with some blood pooling through there. And then the sagittal images are cut from right to left on the patient. The transaxial or transverse views were superior to inferior. So they're cut from the top to the bottom. And then coronal views are anterior to posterior, so the patient's being sliced from front to back. That helps you see that it is located a little more posteriorly, which you also saw on the other images. So that's it for the liver hemangioma. It is a really important test for that. And This image I like to use to transition because it shows you the blood vessels within the liver. The liver is highly vascularized. You have the vena cava coming down and the hepatic vein coming off of it. And then you have the hepatic artery branching off of the aorta. And then you have hepatic sinuses throughout where you have a lot of those capillary beds with the venous and the arterial blood exchanging. Because your liver is a filter, this is one of the ways it's filtering out. So it's highly vascularized with aortic blood and venous blood, or arterial blood and venous blood. And then you also have the portal vein mixing in there as well. And then the next procedure I want to talk about is the liver-spleen imaging. This study has mostly been replaced with other things, but you will see it a lot, especially if you work at VA systems or areas where there's GI doctors or liver specialists that are ordering the test a lot. It's done to look at liver function, but you're not looking at the gallbladder or the biliary system at all. You're looking at the reticular endothelial cells of the liver. Your liver has a lot of functions. It helps regulate your hormones. It helps and aid in digestion. It supports your immune system. It helps to filter your blood. Your liver does a lot of stuff. And so it has a lot of different types of cells in it. And the reticular endothelial cells are immune cells. They're responsible for phagocytosis of particulate matter. This is what helps to filter out the heavy metals and things like that that are in your bloodstream that can be really toxic to your liver. But it just filters out any of those particulate matters that your body has identified as not really useful or that it's not really supposed to be there. So 80% of your body's reticular endothelial cells are dispersed throughout the liver. And within the liver, they're more commonly referred to as Kupffer cells. Other sites of reticular endothelial cells are in the spleen, the bone marrow, and the lymphatic system. Indications for liver spleen imaging are to determine the size, shape, and position of the liver and or the spleen. We can also look at splenosis or splenomegaly. Of course, splenosis is inflammation of the spleen, and then splenomegaly is enlargement of the spleen. You can evaluate focal nodular hyperplasia of the liver. You can detect tumors like hematomas, which is bruising, basically in the liver from trauma, cysts, abscesses, and other forms of trauma. And then you can also assess function in patients with known liver disease, such as hepatitis or cirrhosis. Contraindications are pregnancy or breastfeeding. Of course, breastfeeding is not an absolute contraindication. The patient would just need to be aware of it ahead of time and be able to pump and waste that breast milk for a period of time. Any recent interfering nuclear medicine study, this would be anything that goes to the liver, spleen, or bowel, anything in the abdomen. And then recent barium studies, because that will attenuate and you could get false results from that. So patient prep, they can eat and drink and take their medications as usual. Nothing that really interferes with it. The medical history, though, should include clinical indication for the scan. You want to look at the patient's symptoms, blood work, especially when it comes to liver function tests, things like that, history of alcoholism or drug use, relevant history and results of a physical exam. Do they have any palpable masses, CT, ultrasound, anything like that that showed cysts, bruising, history of trauma to their abdomen recently, results of the liver function test. Usually that's ALT and AST blood tests. But you also want to look at like hematocrit and things like that. Complete blood count and platelet counts as well. When patients have advanced liver disease, that can affect thrombocytes, platelets, things like that in their blood. So this is an example of a liver-spleen study. This is fairly normal looking. You have a lot of increased activity. The liver should be the brightest thing. The liver uptake should be greater than the spleen on this one. And then you'll see some faint bone marrow uptake because you should see liver, spleen, and bone marrow because you're looking at the reticular endothelial cells. It's very common to use a marker. This marker is just a thin piece of lead that has these holes in it. The holes are typically about 1 inch apart, so the whole thing is usually about 5 to 6 inches. And you'll put it around along the costochondral margin. You'll put it right along the same angle and location of the bottom rib. And that marker serves as 2 functions. It's to show the location of the liver, but also the size of the liver. People with advanced liver disease and cirrhosis, the liver will start to shrink over time. And it helps to see if maybe they have an enlarged or shrunken liver. Note their liver is smaller than normal. And you want to look for any cold defects. This image here at the bottom has identified a cold defect. So you want to look at hot or cold spots. Typically non-functioning or areas where there's not functioning tissue will show up as cold. So the radiopharmaceutical for this is 99M technetium sulfur colloid. The dose range is about 4 to 6 millicuries. The typical colloidal size is about 1 micrometer. When injected into the blood, your body recognizes it that it's particulate matter, and your liver, it will be delivered via the bloodstream to your liver, and the reticular endothelial cells of the liver will take that up and phagocytize it and process it, and so does your spleen and your bone marrow because it goes to the reticular endothelial cells, but that's how it localizes. So the method of localization is phagocytosis into the reticular endothelial cells. The normal biodistribution, about 85% of it should go to the liver, 10% to the spleen, and then the rest of it, 5% or so, should go to the bone marrow. It's usually not enough to really visualize the bone marrow because the liver and the spleen are so bright, but it is there. And then variations can occur if there's a problem with the size of the sulfur colloid. If it's too small, it'll go more to the bone marrow. It has to be large enough for the Kupffer cells of the liver to pick it up. And the smaller ones tend to go more towards the bone marrow. If it's too large, then it will get stopped by the lungs, like an MAA study, or it will go to the spleen. And too large particles can also result from excessive heating or high levels of aluminum in the sulfur and the technetium. When you are eluting a generator or the radiopharmacy is eluting the generator, one of the QC tests that they do is to look at alumina breakthrough. And if there is too much alumina, then it will interfere with the sulfur colloid's ability to bind to the technetium, or it will cause other colloidal bonds to form that aren't necessarily good. So if the particles are too large, or too large of particles will occur if there's high levels of aluminum because it actually tends to form more of an aluminum colloidal. And then if there's a lot of heat, that can make the particles kind of clump together and get too big. So just a review on sulfur colloid. When it's made, it incorporates the 99 Tech in an unreduced valence state of +7. This is the only radiopharmaceutical, at least the only one I can think of right now, that will bind to with the technetium in the valence state of +7. Typically, the technetium has to be reduced to a valence state around 4 so that it will form a covalent bond, and that's how most of our radiopharmaceuticals are made. But with sulfur colloid, it's a little bit different. And so it will actually bind to the technetium in the +7 valence state. Because of that, there's no reducing agent required in the cold kit. It's stored at room temperature. It expires within 6 hours. And the critical organ, when it's administered IV, is patients with normal hepatic function, it will be the liver. In patients with hepatic dysfunction, it will go to the spleen. So the critical organ will change a little bit with pathology, but whenever sulfur colloid is injected IV, it goes to the liver, spleen, and bone marrow. And typically the liver then would be the critical organ and get the most of the activity. So when sulfur colloid is given orally, though, the critical organ is the lower large intestine, because remember, sulfur colloid was actually also what we gave for gastric emptying. But you'll notice the method of localization, critical organ, all that is different because we're imaging a different anatomy and pathology, and we administered the sulfur colloid in a different way. So sulfur colloid cold kit is in a nitrogen purged atmosphere. And then contents of the kit have a solution A, which is an acid, solution B, which is a buffer, and then there is the sodium thiosulfate and the edetate disodium, and then gelatin. There's a couple of things that I want to point out with the preparation of that kit. So when it's nitrogen purged, you'll see that with radiopharmaceutical kits that are subjective or vulnerable to oxidation, and the presence of oxidation can make other free radicals interfere with the tagging or the shelf life of it. And sulfur colloid is one of those. So the kit is nitrogen purged to make sure that there's no oxygen in there. And then this is also one that needs to be boiled because the sulfur colloid will bind to the tech when it's in its +7 valence state. It needs to be heated in order for that bond to actually form. So this is one of the ones that gets boiled. And then of course that has to get cooled down before before it actually gets injected into the patient. So the radiopharmaceutical reconstruction procedure is to inject 1 to 3 milliliters, a max of 500, and gently swirl it. Add a solution A, which is the acid, into the multi-dose vial and gently swirl it. Place it in a boiling water bath or heating block for about 5 minutes. Allow it to cool for 5 minutes, and then that's when you would add solution B, which is that buffer. That's going to help keep it bound, and then allow that to cool to body temperature before being injected into a patient. So the procedure for that is you begin imaging about 10 to 15 minutes after injection. This one does not require a flow, and it is not a dynamic study either. The patient will be supine on the imaging table with multiple views of the liver and spleen at the top of the field of view. Acquire anteriorly first for about 500,000 to 1 million counts, and then obtain all the other views for the same amount of time. The reason that you're doing that is because you want to, you're looking for any changes in uptake or uptake intensity, and so you want to make sure there's the same amount of counts per image. Views include anterior, posterior, RAO, LPO, and right lateral. If the spleen is what you're looking at, if you're looking at splenosis or splenomegaly, then you would also take left posterior obliques and left laterals. And then you obtain anterior view with the marker and on the costal margin to measure the liver and the spleen size and to identify any other landmarks. And then SPECT imaging is also useful if focal disease is suspected, just because it helps you slice through the liver and look at those different planes. And then flow imaging can be useful for demonstrating vascularity defects of the liver, but typically it's not done with this study. This is an example of a normal liver spleen study. The liver is the hottest on the image, followed by the spleen. And then the marker images here in the bottom, and you don't typically see the bone marrow because the liver and spleen is so bright. But if you greatly intensify and scale that image, you can see that there's activity in the bone marrow. So for this one, we can see a little bit more detail. We don't need it to be as sensitive. We're not getting quantitative data based on the counts that are present in a certain area. But we do want to see if there's any detail because we're looking for lesions. So in this study, spatial resolution is a little more important than it was with some of the other GI studies we've talked about. So the energy is 140 keV with a 20% window. Collimator is low energy, all purpose, or high resolution. Patient position is supine. The camera will be in the upper abdomen with the liver and the spleen at the top of the field of view. And then injection to imaging time is 10 to 15 minutes. After you inject, you'll start taking the planar images. When you're looking at primarily the liver, you'll do anterior REO, right lateral, RPO, and posterior. If you're also looking at the spleen, then you add the LPO and left lateral as well. Planar images are 256 by 256. SPECT is 128 by 128. Counts are anterior, 500,000 to 1 million. All other views, same amount of time is required for above, and then SPECT is 20 to 30 seconds per step. If you do a SPECT, you do it all the way around in circular or non-circular orbit. When you're processing it, you'll scale and frame the images, make sure they're labeled appropriately. If SPECT is performed, you'll reconstruct the data and display it in coronal, sagittal, and transverse planes. For the image findings, a normal study will be homogeneous uptake of the radiopharmaceutical in the liver and the spleen. You'll see liver above the costal margin. The liver may have a normal Rydell's lobe, which is a greatly enlarged right lobe of the liver that may extend into the pelvis. That's a normal variation. And then the spleen above the costal margin, and it will be seen mostly posteriorly. And then the spleen size is best determined in the posterior view. Some abnormal findings of liver spleen studies. Certain conditions may cause the liver to sit below the costal margin. This could be things that just kind of push the liver down, like emphysema, a subphrenic abscess, or if the patient has a large left hepatic lobe. Tumors, cyst, and abscess will be areas of decreased uptake, so those will show up as cold nodules. Diffuse liver disease will be decreased or uneven tracer concentration throughout the liver. This can be seen with cirrhosis and hepatitis. And then in severe liver dysfunction, also known as colloidal shift, will occur. And this is markedly decreased uptake in the liver with increased uptake in the spleen and the bone marrow. So remember, the liver should be the hottest thing on the image. If the spleen and the bone marrow are the hottest things on the image, then that's called colloidal shift, and that occurs with advanced liver disease such as cirrhosis or hepatitis. This is an example of cirrhosis. You see the liver appears kind of mottled with some cold spots in it. You see a little bit more activity in the spleen and the bone marrow because the liver is a little bit decreased activity. And this is an example of colloidal shift. This is posterior images, and you see that the bulk of the activity is in the liver, or I'm sorry, in the spleen. You see the bulk of the activity is in the spleen. Because these are posterior images, this is the spleen on the left and then the liver on the right. You see a lot more bone marrow than you did in the other images, and the spleen is very, very bright, whereas the liver appears smaller and less intense. Okay, so that's it for liver spleen imaging. The next one we're going to look at is liver also, but this is specifically hepatic tumors, and this is a theranostic study. The study is done pre-therapy just to make sure the therapy is going to go where it's supposed to go. So, primary and metastatic liver cancer accounts for the largest cancer-related mortality rate in the world. The liver is the most common site for metastases for cancer of the abdominal organs, probably because of the increased vascularities and blood flow to it. But most of these patients present with a non-resectable disease. The hepatic pump patency, hepatic shunt patency, or HAPS procedure, it's all the same thing, different names. This is selective internal radiation therapy, and it's utilized to target primary hepatocellular cancer or hepatic metastases. This study relies on increased vascularity of tumors in the liver and the principal blood supply of liver nodules by the hepatic artery. Both of these tumors that I mentioned, or all types of the tumors I mentioned, they do have greatly increased vascularity, and they they cause their own angiogenesis, but then they also hog resources from normal liver tissue, and they have their own blood supply by the hepatic artery. So indications for this test are prior to the therapy dosing with yttrium-90 microspheres, and that could either be the brand name TheraSphere or Seraspheres. MAA mapping is done to determine the extent of arterial to venous shunting to the lungs and to exclude gastric or duodenal flow. We really want to make sure that the therapy is going to go to the tumor and not to the patient's lungs or spleen or stomach or anything like that. So contraindications would be pregnancy or breastfeeding, any recent interfering nuclear medicine study, and then shunting of more than 20% typically means the patient cannot have their therapy. So with the patient education, you'll review their history with the doctor when they talk about the therapy, and they'll plan the study. The radiopharmaceutical is 99-MTEC MAA, macro aggregated albumin. That's the same MAA that we use for lung scans, and the dose is about 5 millicuries. This is administered directly into the hepatic artery in interventional radiology department during the hepatic angiogram. This is something that the physician, usually the interventional radiologist or the surgeon, will inject, and it goes straight into the port that goes to the hepatic artery. This is not something that the technologist has to inject. Typically, we are present with the dose, or we take the dose there and bring the dose back to the department. And then you bring the patient back for images. So the patient will arrive from interventional radiology. Most likely they're being monitored by a nurse because they are under sedation. Place the patient supine with the camera anterior and posteriorly, and then you'll acquire images for about 700,000 to 1 million counts. The field of view will be over the chest and the abdomen. This is important to make sure that the apices of the lungs are at the top of the field of view, and it should include the entire liver at the bottom of the field of view. Special care should be taken not to disrupt the injection site. This is typically the femoral artery. Patient is not allowed to bend the affected leg, and they must have help to move from the stretcher to the imaging table. Typically, they're lifted. Optionally, a SPECT can be performed, and then when the study is complete, follow the facility protocol. Often it's required to return the patient to interventional radiology to complete their recovery. This is what the images look like for the hepatic pump patency study. You are looking at the liver and the lungs and how much activity is present. Now, theoretically, no activity should be seen in the lungs. Sometimes it will be kind of diverted and get to the lungs. And that's really what we're looking at because we want to make sure that the therapy is not going to go there. So the images are, the photo peak is 140 keV with a 20% window because we're looking at a tech-based agent. The collimator is low energy, all purpose or low energy, high resolution. Patient is supine with the camera anterior and posterior. Injection to imaging time kind of depends on when they come from interventional radiology, but it should be fairly quickly. You're not trying to do a flow or anything. You're just looking for activity present. And then the acquisition type is planar. Matrix is 128 by 128 or 256 by 256. The time per view is 700,000 to 1 million counts. So the planar images are scaled, framed, and labeled appropriately. You'll draw a region of interest around the entire liver and then around the entire lung field. And then oftentimes you'll also divide it into right and left lung. And then you'll calculate the percent of shunting. The total lung counts for both lungs is divided by the total counts present in the lung and the liver. You'll multiply that by 100. And then it's also commonly used to do a geometric mean value the same way you do for gastric emptyings. That way you account for anterior and posterior views. The lung tends to be more anterior, or I'm sorry, the liver tends to be more anterior and the lungs tend to be a little more posteriorly. And so that's where the geometric mean study can help make sure it's accurate. So with serospheres, the lung shunting reduction factor, if it's less than 10, you don't need to reduce the therapy dose. If it's 10 to 15%, then the patient will get a 20% reduction of dose. 15 to 20%, they usually get 40% reduction of their therapy dose. And if it's greater than 20, then the therapy cannot be done. And the overall lung dose per treatment should be less than 25 gray. With the TheraSpheres, there's also the lung dose limit, but it's based more on the total grays that will be given to the lungs. So the per treatment is on maximum of 30 grays to the lungs, and the cumulative cannot be more than 50. So this is another example of what it looks like with those regions of interest drawn there on the lungs. And this is looking at the total activity anterior and posteriorly for the right and left lung, and then the anterior posterior activity of the liver. And it was calculated that the percent of lung shunting is 7.35%. So this is what the in A, that's what the hepatic pump patency looks like under the interventional study. And then with B, they did whole body imaging and they looked at the injection area as well as the entire lung field and the liver. And then they also did a SPECT CT to see where the activity was present. This is also helpful for this procedure. And that's it. That concludes the video for the liver hemangioma, liver-spleen study, and HAPS procedure. Thank you for watching. I hope you enjoyed.